Hello, everyone. Thank you all for logging in today. I'm Laura Moore, and I'm the Director of Clinical Professional Services here at Philips Healthcare. My team is presenting several webinars over the next week or so to assist healthcare organizations in managing patients through this global healthcare crisis. Today, we're excited for our webinar on the challenges of preventing ICU delirium with patients in isolation, presented by Lauren Rodriguez. Before I introduce Lauren, I want to go through a few housekeeping items for today's webinar. First, due to the number of participants on the webinar today, we will not have a Q&A session at the end. However, you can enter any questions you have for Lauren to answer by clicking the Q&A icon, should be at the bottom of your screen, and entering your questions there. Lauren will collect those questions and send out an FAQ to all attendees soon. Next, this webinar is being recorded. You'll be sent a follow-up email in a few days with not only the Q&As, but also a link to the recorded presentation. Now I want to introduce Lauren Rodriguez. Lauren is a workflow optimization thought leader for clinical professional services here at Philips. She has a strong clinical background as the proposer, promoter, and implementer of strong, safe clinical processes, hospital, region, and nationwide. She has worked with staff from all service lines using evidence-based practice to improve patient outcomes in safety, quality, and efficiency of care. She used patient safety, systems redesign, or lean, and quality improvement skills to foster the development of a high reliability organization at the unit, service, and medical center level. Lauren has been a registered nurse for 17 years. She obtained her Bachelor of Science in Nursing from the University of Kansas in 2003. Lauren was selected as the Dean's Merit Scholar at the University of San Diego and graduated with a Master's of Science in Nursing degree in Executive Nurse Leadership in 2014. Not only is Lauren a transformational leader, but she excels in systems leadership as well. Her former nursing positions gave her expertise in value-based healthcare, quality outcomes, organizational assessment, high reliability, community health, and policy review. It is my pleasure to turn this webinar over to Lauren.
Thank you so much, Laura, for the great introduction. Thank you all for joining us. I'm really excited to be here and share with you what I've learned in preparing for this webinar. To everyone who are in the hospitals, nursing homes, and on the front lines, thank you for your selfless service and the risks you are taking to save lives. Also, thank you to my former colleagues who I think about every day, and I try to put myself in your shoes. You will always be considered family. Finally, thank you to Philips, who has given me the opportunity to expand my knowledge and continue to help other nurses and healthcare providers improve patient outcomes. Before we review the objectives, I'd first like to take a moment to go over some patient testimonials and their experiences with ICU delirium. He thought the nurses were hooking up poisonous snakes to his arms. They were IV tubing. The time I spent like I was in a huge empty gray space, floating or seeming to float. I actually seen body bags with my children's names on them. I tried to help them but couldn't. The best way to describe it is mental disorganization. It's been 10 months and it hasn't gone away. These testimonials are to me like a bad dream. Just think for a moment what it would be like to live a bad dream every day. This is why I chose to speak about delirium for this webinar. Even as an ICU nurse, I had no idea that delirium has such an impact on individuals' lives. So let's get started. Just to review the objectives really quick, we're going to review the basic elements of ICU delirium, discuss risk factors of delirium and isolation precautions, develop an understanding of evidence-based practice in preventing ICU delirium, discuss the challenges of preventing ICU delirium with isolation patients, and discuss the impact of ICU delirium after discharge. Delirium is defined as a sudden and severe change in brain function that causes a person to appear confused or disoriented, or to have difficulties maintaining focus, thinking clearly, and remembering recent events, A lot of times it fluctuates. My very first experience with delirium, or what I thought was delirium, was only 15 years ago. One of my patients was a post-op open heart. He had turned on his call light, and the great nurse that I went in. Upon entering his room, he's pointing at the ceiling, saying frantically, "There's silver fish on the walls. Silver fish. Do you see them?" Well, I didn't see any silver fish, but he was adamant about seeing the fish. So I called the nurse practitioner who came to see him shortly after. She came out of the patient's room a few minutes later, smiling, chuckling a little bit. She said, "Lauren, do you know that silver fish are little bugs? They really are on his wall." Who knew there were actual bugs called silver fish? And that's what they look like. So my patient didn't have delirium, but if he did, it was probably hyperactive delirium, one of the 3 types. Also the easiest one to identify, which presents as agitation, restlessness, attempting to remove catheters, and/or emotional lability. There's hypoactive delirium, which presents with a flat affect, withdrawal, apathy, lethargy, and/or decreased responsiveness. Or they can have mixed, which is a combination of both. Hypoactive delirium is the most common and has prevalence rates up to 56%. It misleads providers all the time. It appears as if the patient's sleeping. And what ICU nurse doesn't like a sleeping patient? That's why we're ICU nurses, right? So the costs of ICU delirium are through the roof. $152 billion in US healthcare, which is the second highest to cardiovascular disease and diabetes. Yep, you heard it right, 152 billion. When I first read this, I thought it was a mistake. Facilities average an extra $2,000 to $9,000 per ICU patient diagnosed with delirium. This is about 39% higher than ICU costs. The potential savings for a facility, 1 million to over 5 million per year. Now, in looking at this picture, this is a terrible way to secure an ET tube. This facility couldn't afford the securement devices. You know why? They spend too much on delirium. Delirium has an entire laundry list of risk factors: age, respiratory disease, and any mental impairments in a patient's history put them in the high-risk group. Once in critical care, precipitating factors include intubation, lack of sleep, certain medications, and the severity of the illness, just to name a few. ICU delirium is very, very common. Anywhere from 30 to 80% of ICU patients, either intubated or not, will get delirium. Alarmingly, more than 60% of patients with delirium are not identified by the healthcare system. Furthermore, delirium is still considered by many physicians and nurses to be a harmless side effect of hospitalization. And I was one of them. Not only did I think a patient was hallucinating by seeing actual fish on his wall, I know that I missed hypoactive and mixed delirium several times in my patients. So until I started researching delirium, I can't help but to think about all of the harm that we as healthcare providers unknowingly could have been doing and did to our patients. Patients who experience delirium in the hospital compared to patients without are more likely to experience negative outcomes. These include increased hospital length of stay, including hospital-associated complications, prolonged ventilator weaning, Patients experience physical deconditioning and impairments. This also leads to needing long-term care and rehab after discharge. They have higher readmission rates. They also may develop short and long-term cognitive impairment, including dementia, even if the delirium clears. Patients also have an increased risk for mortality in the hospital and up to 6 to 12 months after discharge. They also have a higher risk for post-ICU syndrome, or PICS. Now moving on to patients and isolation precautions. We just had an overview of the basics of delirium. Along with delirium, isolation precautions are associated with several adverse effects, which may result in poor hospital outcomes. So the negative outcomes of isolation precautions are very similar to delirium. They include an increased cost of about $200 per patient per day, not $2,000 like delirium, but still, it's increased cost. They have increased length of stay, higher readmission rates, increase in adverse events, such as falls, medication, or clinical errors. Patients may have negative short and long-term psychological side effects too, including higher risk for delirium. Isolation patients are out of sight, out of mind. How many times have you been in a hospital and the isolation patients are usually in the back of the unit? So they receive less care. This includes, on average, approximately 50% less room entries, 50% less time spent in their rooms, and 50% less physical contact, including half as likely to be visited by their attending. Also, there are fewer progress notes and documentation in their chart. And watch out, HCAHPS scores. These patients are not happy. So there are many common negative outcomes of delirium and isolation precautions, like I had said before. This right here is setting the stage of the challenges to come, both in inpatient and outpatient settings, especially during the COVID-19 pandemic. There's an increase in adverse events, short and long-term cognitive and psychological effects, including anxiety and depression. Increased length of stay, increase in hospital readmission rates, and the big elephant in the room, of course, we saved him a spot, cost. So we've talked about the basics of delirium, negative outcomes of delirium and isolation precautions. Now we're going to talk about evidence-based practice in preventing delirium. First, here's a little history about the ABCDEF bundle. So in 2010, the ABCDE bundle was created. It was groundbreaking research for critical care. Its goal was to provide the care of the critically ill using an integrated interprofessional team and bundled approach to implement evidence-based best practices in managing delirium. This bundle evolved to the ABCDEF, or A2F that people like to call it, bundle, which teaches us how to best care for critically ill patients. So here we are, 10 years later, and the A2F bundle continues to be the preferred practice, having a significant impact for patient and healthcare system outcomes. So the A2F bundle is the gold standard in preventing ICU delirium. Healthcare providers use bundled care because it's synergistic. It works together, attaining the best outcomes by implementing all elements of the bundle instead of separately. The first element is assess, prevent, and manage pain. We all know that managing pain is one of the most important services that we can provide to our patients. I don't think anybody can argue that. The second element is both SAT and SBT. SAT is not the college entrance exam, its spontaneous awakening trials, and spontaneous breathing trials. Doing these daily produce large reductions in mortality, mechanical ventilation time, and length of stay. This requires coordination of the nurse and the respiratory therapist for best results. Third, choice of analgesia and sedation. These prescribed medications are to ensure patient safety, relieve pain and anxiety, reduce stress, and even oxygen consumption. It also prevents patient ventilator desynchrony. Patients spend less time on the ventilator and are more likely to be delirium-free if maintained at an awake and alert arousal state, or lightly sedated using medications other than benzodiazepines. Also, benzodiazepines have been found to increase the risk of delirium and mortality rates. So best sedation practices produce better outcomes. The fourth element is delirium. Assess, prevent, and manage. In this element, the provider can detect missed, quiet, or hypoactive delirium and trigger patient-centered interventions that are outlined in the bundle. This is especially important because medical staff often overlook patients with hypoactive delirium because the patients appear to be cooperative, passive, they're sleeping. The fifth one is early mobility and exercise. This involves actively getting patients off sedation and out of bed, including while still intubated. This is considered one of the most challenging elements of the bundle. The last element is family engagement and empowerment, the newest element to the bundle. Engaging family is considered one of the most important elements in the prevention of PICS, or post-ICU syndrome. As you can see, there are a lot of components to the A2F bundle, and it takes time to implement these practices as a whole in a facility. In the following slides, we will discuss how the bundle makes an impact in preventing ICU delirium. So the results of the A2F bundle are very impressive. Results include decrease in delirium, cost reduction, and improved patient and system-related outcomes. We will show you these on the next slide. So the improved patient outcomes from the A2F bundle include the reduced incidence of delirium, up to 78%, decreased mortality rates, an average 3-day reduction on mechanical ventilation, and up to 65% decrease of ventilator adverse events, including infection and self-extubation. Patients experienced less pain, and studies also found less benzodiazepine use. We use less restraints. There is a 3 to 5 day reduction in length of stay. More patients are discharged to home versus long-term care or rehab, as well as less readmissions to the hospital. Also, patients have a 50% increase in their independent functioning after hospital discharge with the early mobility element. Now, the challenges of preventing ICU delirium. Is it even possible for healthcare providers now to mitigate the risk of delirium? Odds are against us. Many intensive care unit doctors say the pandemic strain on hospitals and the infectious nature of the virus are making it hard to stick to some of the bundle's practices. Dr. Sharon Inoue, one of the most well-known delirium researchers and geriatric physicians, states, "It's taken us a long, long time to develop some best practices for geriatric care in the hospital and ICU. And I just see all of that being eroded during this crisis." So there are common themes in the challenges that healthcare providers face in preventing delirium that can affect the outcomes of an isolated patient. So as previously discussed, isolation patients have less healthcare worker visits, less documentation, less physical contact. So when I look at this first list in the eyes of a healthcare provider, it doesn't seem that bad. So if I was still providing patient care in the inpatient setting, I would be sending out emails, talking to staff, putting signs up on the bathroom walls. It would just be increasing awareness, providing, more ways to modify behavior. But when I look at the list for the COVID-19 patients on the right, this isn't the case. In COVID-19, the 3 themes of general isolation patients may carry over, in addition to prolonged mechanical ventilation, prolonged sedation, nurse-to-patient ratios that are sometimes more than doubled. There's a shortage of hospital beds. And finally, nurses who are unfamiliar with the ICU because they had never worked in the ICU until now. They more than likely received a crash course, if they were lucky, in how to care for ICU patients. And as an ICU nurse, I cannot imagine that. As we know, the ICU under normal conditions is not an optimal healing environment. And most recently, it's been described as a war zone. Besides many facilities not having policies regarding bundled care to prevent delirium, we also know that there are disparities between knowledge and practices. While some of these examples are speculative, based on my own experience, observations as an ICU nurse, this chart provides examples of the challenges in preventing delirium in isolation patients and COVID patients. The first element, optimal pain management, may be compromised. Why? With less healthcare worker visits and contact, pain medication administration and dosing may be delayed. This can cause uncontrolled and prolonged pain. There may be less subjective and objective observations of pain. And with less documentation, including less vital signs recorded, there's less information to assess for pain. In addition to non-COVID isolation patients, COVID-19 patient challenges in preventing delirium include medication shortages. This can result in using the meds sparingly, unable to use continuous strips, and having to administer pain medications and IV pushes. We are using heavier dosages of sedation and more use of paralytics. This masks pain. This increases pain and suffering. Furthermore, opioid-induced respiratory depression is potentially life-threatening. These patients are already severely compromised. So moving on to element B, spontaneous awakening trials and breathing trials can potentially be delayed in isolation patients, therefore delaying extubation. Titrating sedatives for SATs can take time. We're already in there for more time because of isolation, so other priorities may supersede trials. Some facilities have policies that trials must be done by a certain time. If not, they could be delayed until the next day. Also, if trial results aren't documented or the attending doesn't round, orders for extubations may not be placed. I know firsthand that extubations get delayed all of the time. I knew providers who didn't feel like doing it. Many times the nurse, respiratory therapist, and even the doctors didn't make it a priority. Just about a month ago, I received a text from a former coworker who asked me, "Are we supposed to trial our intubated patients daily?" I replied, "Yes, every day. The attendings like it done by 9 a.m. if possible." Did you guys not read the policy and protocols? The reply was, well, we're not doing them, and these patients are stable patients, not COVID patients. The conversation continued, but this shows that when even we know best practices, sometimes we don't do what's best for the patient. So, moving on to the COVID patients, trials weren't and still not being done because of the fear of a patient decompensating rapidly, not being able to bring them back. Element C, choice of analgesia and sedation. So as we discussed before, best sedation practices are vital in decreasing time on a ventilator and preventing delirium. Due to less time spent in the room, sedation scores may not be documented. Titrations may not reflect sedation scores, and most importantly, the patient's sedation may not be at goal level. In COVID patients, they're intentionally induced to a very deep sedation. There's an increase in benzodiazepine use due to the shortages in preferred drugs. Delirium, assess, prevent, and manage. Now remember, 60% of patients aren't diagnosed. Less assessments lead to less identification of delirium. There is a lack of knowledge of delirium. Healthcare providers still think delirium doesn't have long-term effects, as well as lack of recognition, especially hypoactive, which delays treatment and initiation of preventative bundled care. In COVID, the severity of respiratory disease already puts the patient at high risk for delirium. It compromises the most important components of the bundle: prevention, diagnosis, and treatment, which may all be delayed. Again, prolonged sedation and mechanical ventilation. There's also an increase in environmental factors. It's chaos. There's noise, the lighting, many other factors. A patient's sleep and circadian rhythm is, without a doubt, compromised. We're also using restraints much more than before. In the E element, early mobility and exercise, patients overall have muscle weakness, even if they're not mechanically ventilated, due to longer bed rest, length of stay, and unable to resume normal activities. In COVID patients, prolonged bed rest and immobility that lasts for weeks. Shortage of PPE prevents the physical therapy and occupational therapy to treat patients. They can't even follow through on consults. And lastly, family engagement and empowerment. In a study by Sprague, isolation patients had 23% less contact from visitors and more social isolation than if they weren't in isolation. In COVID patients, as we know, family and visitors are not allowed. So as you can see, right now, we know staff are unable to meet the physical, emotional, and psychological needs of the patient. Just by looking at this chart, odds are definitely against us in preventing delirium. So in a few minutes, we'll talk about what we can do now. So when I saw this headline in a recent article by the Washington Post, I immediately thought that there was some groundbreaking new practice besides proning that was discovered to improve outcomes. Well, I should have read the subheading, but I jumped straight to the body of the article because this wasn't the case. I was surprised to read it was referring to the ATF Bundle. Dr. Wes Ely, an ICU physician and one of the most well-known experts in ICU delirium, states that healthcare providers didn't follow the bundle principles in COVID patients because, quote, everyone was very scared, and now we are getting back to our basics, end quote. In getting back to our basic care, now that physicians know that it's safe in some cases, we should start seeing better outcomes in the COVID patients. So you may be asking, what about treatment for ICU delirium? We've heard how to prevent it. Unfortunately, there is no specific treatment for delirium. Sorry. Instead, treatment focuses on several basic principles, and guess what? The most important one is the ATF Bundle. So if you haven't already taken necessary steps to implement the bundle, there are several resources and toolkits available online. I'll include these on one of the last slides. The other supportive principles, which include avoiding factors known to cause or aggravate delirium, and also certain medications. However, pharmacological intervention should be used as a last resort because studies have consistently found that the use of antipsychotics compared with placebos did not significantly reduce, or even reduce at all, the duration of delirium. Also, benzodiazepines have been shown to make delirium worse and, like we said before, increased risk of mortality. Personally, I can remember many, many times how relieved and even excited a coworker or myself got when the doctors finally ordered vitamin A or vitamin H, Ativan or Haldol, and many times it didn't work. So right now, I would like to apologize to all of the residents that we had begged to give us medication orders to help the delirium, in which many times they were right, probably wouldn't work. And as always, patient safety is a priority. Control dangerous and disruptive behaviors to avoid harm to the patient or others, and always try to avoid restraints. So as we know, delirium is upsetting to patients, their families, and healthcare providers. It's our responsibility to do whatever we can to prevent it. So what can we do now? In the most ominous circumstances, supportive measures are the most realistic to implement. First, we have to remember that when patients are sedated, they aren't necessarily asleep. They can hear you, and if they aren't delirious, they can understand you. One of the days that I was working, I had a patient come in. I couldn't remember his name, but I remembered him, and I remembered how sick he was, and I took care of him for a few days in a row, completely sedated. But he came up to me and he said, "Lauren, I remember you." I said, "Wow, really? I mean, you were sedated the whole time." He's like, "I remember your name." He said, "It's because you were so reassuring. You were the only one that would come in and introduce yourself every single time and tell me what you were going to do before you touched me." He remembered that. And that is amazing to me. And that just validated all the beliefs that I had, that they can understand you and they may even remember you. So the easiest thing to do is introduce yourself and others every time you're in the room. In an article by the Huffington Post, providers are placing pictures of themselves on their gown. This has made a huge difference for patients. You can also orient and reorient the patient as often as you can, and please do. Have a clock and calendar in the room that's visible to the patient. I know where I work, the batteries were always out of the clocks, and then we couldn't reach them, and then it would take several days, if not weeks, to just put batteries in a clock. Also, engage family. Use a live video streaming application to encourage family presence, communication, and support in the ICU. Ask family to bring items from home, especially pictures and sensory aids. Patients need hearing aids and eyeglasses. They will pretend that they don't and that they can hear you. They're lying, and we fall for it. Also, we need to provide education on delirium, including at discharge. Follow-up care may be needed. Patients also need cognitive stimulation. Provide puzzles or cards for them. Do whatever you can to decrease noise. This includes adjusting your alarm settings, even if it's just the volume. This will also decrease PPE and promote rest. Evaluate your lighting and other environmental factors. The smallest interventions can make an impact. Here is a guide that the Hospital Elder Life Program or HELP organization posted recently. Some of these interventions may work for your facility now. I will include the link to access this tool in my follow-up email. So just to name a few, we're just going to read from the second column because that's what really pertains to us now. It says, provide a hospital kit. Provide instructions on range of motion exercises, provide puzzles, and educate on delirium. So what we're seeing now in COVID is that there's a ton of delirium, says Dr. Eli. And that's not just in the US. China and Italy reported a significant increase in delirium during an individual's ICU stay, and if they survived after discharge. This is what made us aware of what was coming. So I know this has been a crash course in delirium prevention for isolation patients. However, I want to bring awareness to our future potential crisis and why it may have an even greater impact for years to come. So among the harmful effects of possible post-ICU is that post-intensive care syndrome, or PICS, which is defined as new or increased physical, cognitive, or mental health impairment in a patient after hospitalization in a critical care unit. PICS-related impairments often have a profound impact on patients' and families' lives. There are pronounced psychological effects, such as depression, anxiety, PTSD, and may even result in new onset of dementia that's not reversible. There's also financial and physical effects. Approximately 1/3 of patients don't go back to work. Another third of patients do not go back to their pre-ICU job or at the same salary. 1/4 of the patients require assistance in activities of daily living a year after ICU admission. This definitely has a tremendous effect not only on patients, but on family members as well. Physical and cognitive rehab may be needed, which can take as long as 6 to 12 months. What insurance company will pay for that? So in an article by Sophia Wang, it brings awareness for the need of geriatric psychiatric medicine due to PICS, even before COVID. She states, it's realistic to believe that healthcare will be facing an unprecedented situation and providing services for chronically ill older patients who have survived their ICU hospitalization and experienced delirium. Realistically, there are several elements in the A2F bundle that can't be implemented at this time. However, we as healthcare workers, as well as the general public, need to be aware of the future impact of COVID-19 on the ICU survivor population. Now, on the other hand, we are getting help from the media. For the first time, ICU delirium and PICS is getting more attention than ever before. If you've been watching the news, following social media, you may have seen these articles or one similar. This article was featured in Greater Milwaukee Today, and this one from NBC News. And this article was featured in Science. Also in the news, individuals have been sharing their stories of experiencing delirium during their hospitalization with COVID and the effects after discharge. Many are diagnosed with PTSD. This CNN news story interviews a 40-year-old nurse and his wife after his discharge from the ICU. He left the hospital unable to walk or take care of himself. Even as a nurse, he didn't realize the type of impact delirium can have on your life. This interview is now one of many tragic stories of the after effects of delirium and COVID-19. Here are more testimonials from patients and their experience with delirium. I've seen doctor after doctor and they look at me like I'm nuts. I couldn't read, concentrate, fill out the application for my next round of family practice boards. That's a doctor. I nearly ended my life a few times. My family believed I was just faking it all. Experts say the best way to help patients avoid such post-ICU stress in the first place is through contact with loved ones, which is why experts added the F in the ABCDE bundle. ICU patients need to have humans around to orient them, to calibrate them, to touch them, to look in their eyes, and make them understand what's happening. But that's exactly what the COVID patients won't get because they're all being isolated. Thank you so much for being here with me and listening to this webinar. I really appreciate your support. I hope this has given you more insight into the challenges posed by ICU delirium. Please share this information with your colleagues, coworkers, even friends and family. If you're a healthcare provider, please take the time to evaluate your staff's knowledge of delirium and the effects that it may have on your patients. Provide education about delirium and try to incorporate any part of the bundle that is realistic at this time. I was one who didn't know there were long-term effects. I wish I had more education. Also, implementing small steps now can have a meaningful impact on patients' lives. If you don't have resources available, there are excellent websites that have tools you can use in your practice. So if you have any questions, please email me at the address provided on the webinar confirmation, the reminders, and follow-up email. I will answer any questions posted during the webinar and send in an FAQ, as well as a list of references available upon request. Before we end this webinar, I would like to share the two upcoming webinars hosted by my colleagues, Christine Perez and Ray McLean. Tomorrow at 1 p.m. Pacific Standard Time, Christine will present Supporting NICU Families During Times of Separation. On April 28th at 3 p.m. Eastern Standard Time, Ray McLean will be hosting Remote Monitoring of Isolation Patients with guest speakers Sarah McCaleb and Pete Stribling. Thank you again for listening to the challenges of preventing ICU delirium with patients in isolation. Take care, everyone, and please be safe.